Ladies and gentlemen, boys and girls, welcome to yet another exciting Editor's Insights episode of the Indian Journal of Anaesthesia podcast. It's our 32nd episode, and it gives me great pleasure to welcome Professor Vrushali Ponde to this special Editor's Insights episode, which happens to be the first of the year 2025. Dr. Vrushali is presently the president-elect of the Asian Society of Paediatric Anesthesiologists, which is called ASPA. She is the program head for Pediatric Regional Anesthesia in the World Federation Society of Anesthesiologists. She is the deputy chair of Pediatric Anesthesia Committee of the WFSA, a visiting professor at Hamamatsu School of Medicine in Japan, chairperson and the past president of the Academy of Regional Anesthesia of India, chairperson of the Board of Studies of AWARE India, a very prolific writer, having had 3 editions of her book, which is the Illustrated Manual of USGRA Anesthesia in Adults and Children, which incidentally is also translated into the Japanese language, and also editor of the textbook of Coexisting Diseases and Pediatric Anesthesia, and has represented our country on regional anesthesia in various fronts internationally, with more than close to 90 publications across both international and national platforms, and a very active musician, I would say, a sitar player. So welcome to the program, Dr. Shali.
Oh, such a pleasure. Such a pleasure.
And we also have Dr. Rakesh Garg here. Dr. Rakesh, welcome to the episode.
Thank you, Dr. Murali. And let's start our first Editor's Podcast for year 2025 with a good note with ever smiling Dr. Murali and a great personality, Dr. Vrushali Ponde, with us.
Yeah, it's actually wonderful to have a positive group of 2 people with me this evening to discuss more about what's happening in pediatric anesthesia. So, Dr. Shali, just to start off the discussion, what are the unique challenges in pediatric anesthesia when we compare it to adult patients? Just a brief intro to get the conversation started.
Oh, yes, sure. Before I break it down into a couple of considerations and different aspects, let me just begin. As you just said, yes, I'm amongst 2 brilliant minds in the anesthesiology of this country, as it were, and I'm sure the vibes are amazing. And let's get on with some beautiful conversations as well. So the first question that you have put in across is unique challenges. Yes. So let's break it down into different considerations, because there is a plethora here that we look at when it comes to pediatric anesthesia, and that's how it's pretty unique. That's because now you see the social fabric is changing. So more and more preterms, because elderly mothers, and so preterms, neonates, infants, toddlers, preschoolers, schoolers, adolescents. So we have a range here. It starts from maybe 600 grammer who can come on table to say 95 to 100 kilogram adolescent. So having said this, we can still go a little into considerations of anatomy, physiology, and psychology, because that is where the crucial differences would really come up. And let's go to the smaller babies so that it really becomes very informative for all of us to ponder upon. Well, the airway itself is something that needs to be considered, because the highest amount of incidences are in the airway and intubations. So a large head, a smaller oral cavity, a bigger tongue, omega-shaped epiglottis, a higher placed larynx, everything is as if paving way for difficulties. And then the narrowest part being the cricoid. Although there are tubes of cuffed and uncuffed, the anatomy has still remained the same. It does pose an issue here. Other systems such as nascent CNS ready to be get damaged with our hypoxias, hypotensions, and secondly, that robust pain response that it gives, because there is no descending inhibitory pathway. They can't even pinpoint a pain, but there is no doubt that there is a robust response to pain stimulus. The conuses are ending lower, the dural sacs are ending lower. Well, I'm just giving you the gist of what is coming to my mind. So you can look at liver functions, not that well developed, kidney functions, not that well developed, enzymes, well, they haven't reached to their fullest temperature. That's one of the biggest issues here. So hypothermia leading to metabolic acidosis. I'm telling you the end product of it. There are so many things in between. And then the volumes distribution. One of the biggest, fascinating thing is there is a small neonate, but the milligram per kilogram dosages are more than adults. Volume of distribution is higher. So oxygen consumption is higher. Reserves are less, consumptions are higher. I think it just comes as a full package of challenges, when you are in a neonatal or an infant theater. So this is what I can put to you in nutshell. Physiology is here what we just said. Psychology is totally different. It starts from toddlers because a toddler has never left the mom. Never went to school. There is no separation at all. So toddler is a different challenge to separate. A schooler is a different challenge. Go to adolescents, false sense of bravery. They come inside and they show their true colors. 100 kilogram probably is going to talk to you as if I'm the boss here and comes inside and sobs like again a kid because they are children finally. So, and then family. Well, so it's all together. In other words, you just have to be there as an evangelist and make a happy vibe. At least psychologically.
I know it was a very difficult question to start, trying to kind of summarize the entire pediatric anesthesia in a few minutes. But now I would like to take the question to Dr. Rakesh. Now, he definitely receives a lot of articles, case reports, letters to editor, which are titled, "We did this challenging case. We did this something rare syndrome." Now, talking about all these challenges that you spoke, which are inherent in pediatric anesthesia, how does he see as an editor-in-chief when he gets these reports, Dr. Rakesh?
I think this is interesting. And when Madam has summarized the challenges, I fully agree that that's why pediatric anesthesia is a separate specialty now. Many fellowship programs are being done, and probably DM course is also being started into this specialty. And because of these challenges, it has come into picture. But when we see a challenging case versus its publication, what I see as editor-chief is what's the novelty. Say, for example, a syndromic child, a Piare-Ribin syndrome or a Tricia-Collins syndrome, Madam mentioned about difficult airway, or a preterm with large occiput, meningomyelocele. Now, these all are potentially difficult airway. And we know it because they are in textbooks, they are mentioned, and we know that these are the difficulties already existing. We have a lot range in the airway management scenario with regards to the equipments available, with regards to the expertise, with regards to the center. And each will try to do it in a different way. But if I say it, what is it for the readers? Now, we need to understand, getting a challenging case done is for your experience, for your success, for your quality of work that you are doing it. And that's why people are coming to your center to do it. But what is for other readers? Say, for example, a difficult airway, and the authors or clinician says that they did it awake intubation under spontaneous ventilation using sevoflurane titration and then secured the airway by topicalization. Yes, I agree it's a challenge one, but that's a standard of care actually. And they have followed those actual standard of care. So we should appreciate, and that is what my reply would be. Excellent challenging case, you did it as standard of care, but no novelty into it because you as a pediatric anesthesiologist is expected to do so. If you have not done it, this means you are not trained for pediatric anesthesiology and you should not be doing that case. Now, the second thing is, every time I always give them a clue, and wherever I take a session, I always say, when you get a challenging case, please review the literature a day before. And it is very important. And I have done it for the last 20 years. If I have a difficult case tomorrow morning, I will just review the literature, add on to my experience, and see what difficulties people have already faced it, and I should be following into my case. This is one. Now, since I have already reviewed the literature, if something new happened, some new difficulty happened, something new challenge happened, something differently I did it, this is what needs to be emphasized. So this is, I think, very important for all the potential authors challenging case is not for every readers. You are expected to do so. But if something differently done, something which has happened unexpectedly and you manage it, which has not been reported earlier, and that's what novelty is, and that's what you need to highlight. And it may be in a small paragraph that this was the challenge and we did it, maybe a letter to editor, rather than writing a full case report. So this is how a challenging case versus its publication carries its importance.
Now, I understand now the low-hanging fruits when it comes to publications have already been plucked now. So people have to definitely read what's there in the literature. And as you said, if there's anything novel, anything that people can learn from, probably publish that. Now, coming to Dr. Vrushali, now, safety protocols have evolved in a very big way in the last decade or so. And we have definitely seen a lot of publications coming out on similar lines. Now, from your viewpoint, being on the various committees that you are in, what do you think are the most critical safety protocols when it comes to pediatric anesthesia in the last decade or so?
Actually, Murali, I'm really glad that you've asked this question to me because it gives me a doorway to speak something very fundamental about it. Uh, hey, there are still critical incidences occurring of over 5% in anesthetic procedures in infants and neonates. And it largely depends still on the skill and knowledge of the person who's giving them. So it was very imperative for us as pediatric anesthesiologists to have something which will spell it in a very proper manner for everybody. And there are quite a bit coming up these days. Especially the SPA has a good app which gives PD Crisis, a very beautiful, easy, free app. And it has dealt with around 28 to 29 critical events and how they can be handled in a very simple manner. With Asian Society of Pediatric Anesthesiology, we have come up with a course called Perioperative Life Support. Here we actually go physically in each country which invites us and we liaise with their national body, if at all they have in pediatric anesthesia. And then we run a 2-day course which gets from the very basics of perioperative life support. And then we tailor make it in as per the country. Suppose if we go to Cambodia, their demands are different. Suppose if we go to a more evolved country, their demands are different. So we go wherever and fit in there. And ESPA has wonderful guidelines as well coming up, especially the fasting guidelines have come up. So I guess, yes, there are definitely guidelines and we must be aware of it. And even the safety protocols, yes, there are.
And what about the technological advances? We are seeing so many new gadgets coming out, and anesthetists are now marrying themselves to certain gadgets and feeling that, yes, this belongs to me and this is my baby. So what is your take on what advances in technology and which have made an impact with regards to safety?
Well, yeah, sure. Ubiquitous application of ultrasound. Focus. They all are here expanding. Probably everything has a role. However, these two really have made a lot of impact. So, coming to certain monitoring techniques such as Massimo signal extraction, because we know hypothermia, we know hypotension, so it helps in babies for sure. Hemoglobin trends with non-invasive pulse oximetry is available now. Near-infrared spectrometry coming up. Transcutaneous carbon dioxide monitoring may find a way here. And video laryngoscopy, of course, it's almost becoming a standard norm. So yes, there are technologies coming up. We have now pediatric airway scores. We didn't have them before. So there are advances in thoughts. There are advances in technologies. And again, monitors and ultrasound on one side.
Another question which comes up here is, how does somebody train in all these new advances? Now, compared to the adult population, now if somebody were to learn POCUS or learn an ultrasound technique on a workshop, let's say on the weekend workshop, do you think they're qualified enough to go back on Monday morning and try these blocks?
Catch question. Yes, no, I fear that. To be very honest, I fear that. Because if I take a focus of RA and POCUS 2 days and come home, I fear that. because I would show them, okay, this is the way you hold the probe and that's the way the needle goes in. It takes a lot of doing under an expert to go back and really do it on an infant or a toddler, leave alone a neonate. So
Thank
I
you.
guess
Dr.
there are
Rakesh, do
no
you have,
short.
do you have anything to say here?
Yeah, absolutely. I think, Dr. Murali, you raise a very pertinent question. And this is a tagline for me that when we do the workshop, please don't go back and do it on the difficult patient for the first time. And don't be very sure that a wonderful mentor, a world-renowned mentor has come up. He has taught himself or herself in this workshop. And now we are the best. No, because everything has a learning curve. And as Madam had mentioned, that neonates, preterms, they are a special group of population. They are not young adults. They are not young kids. So they require a special care. They require a special respect. Have some mentor into your team. Do under supervision to learn that learning curve. And I would strongly suggest when you're talking about infant, newborns, and preterms, it's always that one should have some, just not a week or so, maybe a couple of months, because they are fellowships and DM programs, to get expertise under those mentors and supervisors, and then gradually take over. And second thing is, I think what my teachers have told, though people say that technology will give everything, but when something happens, technology also fails at times. They will not give the true value. And this is what science has proven recently. Say, for example, let me put you cardiac output monitor, started a decade back, but it has very few data into it. And it was giving all wrong values. When people started using it for non-liver surgeries, all data were wrong. But now we have millions of data, and now cardiac output monitors has come into multiple versions, and it is giving the right technique. So people should know that these technologies are also based on the data which has been input into them. And as an academician, as a clinician, we should know that this data has come from which population. Does that population belongs to my population, which I'm catering to? And this is what technology has a big limitation. And we should be aware of that limitation when we are using it for our patient management.
Thank you. Dr. Vrushali, question to you about this learning curve. Dr. Rakesh mentioned about the learning curve. What is, in your experience, the shape of this learning curve when it comes to USG-guided blocks in children?
I don't think it ever ends, to be very honest. Having said that, there are certain blocks which are very simple, and there are certain blocks which aren't. The dexterity that you really require to work in the pediatric population is really unique, because everything is superficial and things can go wrong even in the most superficial planes, in fact. So it takes around, I don't know how to put it. It just takes quite a few months to understand first how to reach the most superficial structure, because by nature they all go a little more deeper.
And what about the blocks? Which block do you think has shown the most promise in the last few years? No.
If you ask me, I would still rate the caudal epidural as one of the most important blocks today in pediatric regional anesthesia. And I do understand and get it that we ourselves say that go more peripheral, but this is a simple block. This fits so many indications, and it is very easy with any modality. Landmark, PNS, ultrasound, they all are fitting very well with similar success rates. I'm not talking of complications yet. So we'll start with caudal. Then, of course, that is a femoral block. There is the sciatic block. They all are great. In upper extremity, we just had a Delphi study, in fact, done. In upper extremity, it's the axillary, it's the supraclavicular, and then comes the intraclavicular. The interscalene would go further away, because in children, we don't get so many shoulder cases. We get more of forearm works or the supracondylar fractures more. So each block has its place. Anything that can be done in an adult can be done in a neonate with a fitting indication and fitting expertise, is what I would answer you as. Yes.
Okay, so now moving ahead, now we have covered a little. Okay, Dr. Rakesh has got a question here.
So I think, Dr. Murali, what Dr. Vrushali Ponde has raised a very important point. I think I just want to re-emphasize for our listeners. One, it is not always maybe right that after this workshop, you hold a probe and a needle with a local anesthetic and start it. Probably she has given a very important point when we're talking about anatomy. Let it only be the probe for some time and identify the structures before putting up the needle or pricking the needle with the drugs. Once you identify the structures well, probably you were asking about the learning curve. So I'll put it that for regional blocks, especially when we talk about pediatrics, Dr. Vrushali Ponde can correct me if I'm wrong. Let it be first probes on the children looking for the anatomy in a couple of time. Once they are sure that this is the plane, this is the area, this is the reason, then subsequently they can pick up the needle under supervision and they can start with. And second important point is it depends upon whether you're working at a high volume center or a small volume center. If I'm doing one pediatric case in a month, and if I do 20 cases in next 2 years, it is not equivalent to the same person of 20 cases in a month, because you tend to forget over a month when you come for 10 cases. So it also depends upon the center you're working. If it's a high volume center, you'll be well versed in 3 to 6 months. If it is occasional, you are an occasional pediatric anesthesiologist, probably you need some extra training. It cannot be extended in numbers over the extended duration. So this, madam has extended, very nicely mentioned. I just thought I should rephrase and emphasize more importantly. Madam, if you want to add something.
Yes, you're absolutely right, because I guess the way we are differentiating population into those who are ultrasound guided population and those who don't use ultrasound, we would like to say occasional pediatric anesthesiologist and hardcore pediatric anesthesiologist. So if you come to a center where there are a huge number of cases, at least say around 350 or 300 pediatric cases per month, you're going to get trained far more faster. And then probably if you do those many cases, or at least a couple of cases per week in pediatric anesthesia, you're going to lose those skills.
Dr. Shah, another question regarding research here. What are you seeing as a trend when it comes to research in the regional anesthesia space in pediatrics?
Yes. The Delphi study was mostly conducted by us. It's going to be soon published in the RAPM. We actually took into account the occasional pediatric anesthesiologists, which are the most simple blocks, which have more safety, less complications, and would fit more indications. So we picked up, say, around 6 and soon it will be published. So research is going ahead in pediatrics, regional anesthesia, in many trials. First, we were obsessed with central neuroaxials. Then we came to the upper extremity. Then the facial planes took over in a very big way when it came to ultrasound applications. Now the head, face, and neck is really going strong, especially the left lip and palate. So that is what is coming up. There is so much new literature coming up in the suprazygomatic maxillary nerve block area. The regional blocks for tonsils, that's going on in a big way now. So all those surgeries which we felt we did not do very well with RA in the postoperative period, I think now that is coming in forefront, for sure.
Yeah. Now you nicely led me to the next question, which I wanted to ask was about cleft palate and cleft lip surgeries and the programs which happen across the globe.
Yes.
When somebody is designing a large scale, say a cleft surgery or a cleft lip program, what are the key things that they need to keep in mind? The listeners, some of them might be interested in doing such things.
So epidemiology would say that while we are speaking, every 2 minutes, one cleft lip or one cleft palate is born. So that's the epidemiology we are looking at. And I'm speaking about 10 years back up. So today, it might have just decreased a bit, but it's one of the most common deformities that we see. So what we really need to look at is whether international or national program. The first thing that we look at is the epidemiology. Then how do we set the infrastructure, the workforce? The workforce is we anesthesiologists, of course, the surgeons, the pediatricians, the postoperative team, the OT technicians, because everything is very young in cleft lip and palate, the quintessentialness of this is, if you do cleft lips and palates, you almost know the entire pediatric anesthesia, because every aspect of pediatric anesthesia is here. Multidisciplinary care has to be looked into, as we just said. Then the community awareness has to begin. And above all this, the financial aspect and the stability. That has to come maybe from NGOs or so many hospitals bend backwards to accommodate this program. We have one which, I'll share it with you later. The monitoring and evaluation of what we have been churning out. Suppose if we are churning, say around 100 cases a month, then it's good to get audits and see what's happening there. Researches and evaluations also could be a point of consideration when we have volumes, and again look back, what better can we do through audits, of course. And then of course this is a very fertile ground for clinical questions to surface, and then we are answering them. Ethical considerations, definitely cultural considerations come into play, and policies, national policies or international policies. In a nutshell, when it comes to a clinician like you and me, then it comes to infrastructure, workforce, multidisciplinary approach, postoperative.
And Dr. Rakesh, a question to you. As an editor-in-chief, where do you see the cleft lip pilot programs leading to better research or audits? Any tips for researchers out there who are involved in these programs, or even clinicians who are involved in these programs? How can they contribute to the growing evidence?
So when we talk about these programs, probably I will put it, now what are we looking for is a multicentric approach, a multicentric data collection. Now, if you see the India itself, the various programs, which is NGO supported, government supported, and even the individual hospitals, large number of palate repairs, cleft lip repairs are being happening. Maybe like 6 smile trained people supported by international organization. What we need to do is, these group of patients are challenging, and the complication rate in today's world, when we talk about safe anesthesia practice, is not in percentages 1-2%. It will be 0.1, 0.01%. And we want to identify those things also. And when we want to say a complication is happening in 1 in 10,000, probably I need a data of 50,000 people to say that this complication happened, and probably this should have been taken care of. So we have to come at some platform, and leaders like Dr. Ponde, they have to come together to bring all those data into some registry, because she holds a leadership in various pediatric professional bodies, that if we can collect those data and put it forth, even like simple observational study or observational data of say 50,000 or 1 lakh pediatric population, and come up that this is what we have seen. This is the lacuna in the existing clinical performance of the perioperative care for pediatric patients for this group. And this is where we need to have some consensus among the experts, maybe a Delphi. And this is where, based on the Delphi consensus, we have the research question, because Delphi is just based on the consensus. And when talk of the rare complication, even Delphi, which is primarily based on the expert consensus, if they have seen one complication just in last 10 years, 15 years, probably we are missing something, other thing also. So we have to collate those data probably on national and I will say international level, and try to identify the weakest areas into them, try to identify the missing risk or complications into them, and then making some more safety programs. So we started with safety program, and this is how we can give much more robust platform for doing much more robust research to improve our patient outcome. We talked about the maternal mortality rate. We also have to think about perioperative complication rate. Now we will not be talking about perioperative mortality rate. What we have to talk about is perioperative complication rate, and probably, which is coming for adults, I'm sure in the coming time, we will not be looking for those soft outcomes, hospital stay, chances of hypoxemia, chances of bradycardia. What we are looking for are two things. One, the quality of care. Probably in adults we say quality of life. In pediatrics, a little difficult to understand it. And second, and the most important, what if this care is not provided? What would happen to this small child at the age of 30 years, 40 years, 50 years? And when I was going through literature, we say that our body has a lot of reserves. Even 50% of kidney does not function, 50% of heart does not function. It will not be obvious to us. Is perioperative care saving even a single nephron, a single myocyte, a single gray cell? And that will be the end point. I'm just going very micro research here. But then we have to think of just extubating a child, pain-free, having a breastfeed probably may not be sufficient. What we have to look for the long-term impact of what we have done in the perioperative care 3, 4, 5, 6, 7 decades later. So I think this is how we need to look for the future. I think this is quite a nascent phase right now. But I think looking towards Madam, who is an international leader, probably some insight, some input maybe started from India, and we can take a lead here.
In fact, we are coming up with a data on perioperative feeding. Like we are trying to relief how much children really consume the feed in the post-operative period. But what you have pointed out of we want a robust data of that kind, yes, I guess we can lead that. I'll take your point. Thank you.
Dr. Rakesh, that was quite deep actually. It made me think quite a lot, how as an anesthetist we can impact the functioning of one nephron, one gray cell. I think that was quite a deep thought there.
Yeah.
And I will take the liberty in probably announcing to listeners who are listening to this podcast that if they have any ideas of research, can they contact both of you?
Sure.
Absolutely. I think
anything that they would like to do?
Well,
yeah. So especially if there are a lot of young minds, in the country now with
yes,
very rich ideas. So, probably what you're talking about when it comes to having a multi-centric pediatric research net kind of a system, I think even now with the College of Indian Society of Anesthesiologists taking a lot of new initiatives, you being one of the associate deans there, and Dr. Vrushali being, all in regional and pediatric anesthesia societies, probably can come together to do something significant and very interesting, actually.
Maybe that is why we are serendipitously here, speaking in a podcast.
Yeah, probably. Now, Dr. Vrushali, that takes me again very nicely to the next topic that I wanted to ask you was, what is the current evidence regarding the impact of what we do as anesthesiologists on the developing brain of a child?
Well, all right. To answer this, let's start considering whether we have a robust evidence to say that it indeed does happen, or are we chasing a ghost? The gas study, the study of general anesthesia and spiral comparison trial, the Panda study, the mask study, they all finally came down and suggested that 3 years of saddle exposure does nothing. In other words, repeated exposures might. So avoid repeated exposures. We never took into consideration perioperative hypoxemia. We never took into consideration the hypotension swings that happen during the surgery. We never took into consideration what happens to the cerebral circulation when hypothermia sets in. And so there are several things that add on to the nascent brain, as it were. Having said that, we have one study that is coming up, or that has in fact come in done by Wright, and it is published right now in just last year. What they said was, they came up with a very good study. It is very difficult to pick up as a group which was given general anesthesia and which wasn't given general anesthesia and compared with long-term outcomes. It's very difficult to do that. But again, this particular group is serendipitously again got a group of this kind in respiratory disorders. So in Australia, they had these groups. It was an extension of the study which they were doing a cystic fibrosis. So there was one group which was treated by bronchial lavage under general anesthesia, and there was another which was not treated by that, and they wanted to compare that. And I extracted the information out of that study, in fact. So what they are saying is, repeated brief exposure to GI in young children is likely to be associated with poorer neurodevelopmental outcomes. So this is what they now say. So no functional impairment in attention, intellectual quotient, executive functions, or brain structure. So they are kind of putting an end to the debate, as it were, at least currently. And the evidence is very, very new.
We talked about neurotoxicity of anesthetic agents, but when it comes to pain management, is there anything there?
You meant to say pain management doing something to the brain, or you're trying to ask me what's new in pain management?
Apart from regional anesthesia, anything new happening when it comes to managing acute pain in children, perioperative pain? And does it have an impact?
I think no matter where, in which scenario, pain is going to have a huge impact on central nervous system in any age, and neonates even further, infants even more. Well, how I can put it to you is, we are now going a big way into treating pain even before it occurs. So preventive concept was always there, but now it's even more emphasized with gabapentins coming into picture, even as something as simple as paracetamol, even given before taking the child up. Intraoperatively, of course, a profound pain relief, always aided by RA. You look at air protocols, they will always place RA plus multimodality. So we are going a big way there. Continuous catheters are coming up in a big manner. Acute pain protocols are even more followed better. There are teams coming up.
And you just mentioned about, little bit about the ERAS protocol. You just mentioned that regional anesthesia is coming up in a big way. Now, how is it different from an adult population, and in what, I would say, surgeries or in what scenarios would you be looking at ERAS protocol in children?
ERAS protocol can be looked at any surgery for that matter. Even ERAS is coming up. The fundamentals are the same, such as a good pain relief. First of all, fundamentals would start from education of the family as to what ERAS is and what is expected out of them. That's the major difference between adult and pediatric. The primary caretaker is a very important person in ERAS protocols, because ERAS protocols actually lays a lot of responsibility on that primary caretaker. Like, pick up the signs of pain when you go home, pick up the signs of why the child is crying, pick up at what point you come back to the hospital if the child starts puking. So you need to have a very, very sensible person to look after the child. The responsibility is in a big way here. So that's how the pediatric and the adult is totally different. So it's, first of all, team communication, good communication, the interdisciplinary communication. All this has to be geared up for ERAS. The principles, again, as I told you, after this, the principles are the same. A good pain management, a access surgery as and when possible, so that the length of stay in the hospital decreases. A good PONV, stringent PONV protocols to be followed. And then a discharge criteria, which is very well agreed upon with the surgical as well as the anesthesia team. Early feeding, like stop the, how do I put it to you? The first step guidelines, no, I'm giving you another question, right? The first step guidelines have to be followed in a very stringent manner. The post-fasting can be as soon. So feed them as long as you can with clear fluids, and still the clear fluids as soon as you can. All of this actually does come to a
Dr. Rakesh, have you got anything to say on this point?
Yeah, absolutely. I think Madam has mentioned clearly that ERAS protocol in various surgery for adult patients, they have been put up. I'll put a point here that when we talk about the ERAS protocol, there are certain points which are for pre-op, certain intra-op, and certain post-operative aspect. And they vary depending upon what type of surgical procedure is there. So I think we can always suggest the pediatric anesthesiologist leadership to come up with a priority points when we say the compliance of the RAS protocol in a perioperative care, we never want, we want 100%, but we say that, okay, 70-80% is acceptable because there will be a lot of variations because of many aspects. So I think at this juncture, I will request very strongly to the pediatric anesthesiology leadership to come up with certain priority points of the RAS protocol, because feeding fasting, everybody knows it. Even Indian Society of Anesthesiologists has brought the feeding fasting guidelines, and we have tried to incorporate certain things into the feeding fasting guidelines. So we have to identify those, say, 20, 30 or 40 points of RAS protocols, maybe sometimes surgery specific. And we can say that to begin with, it's not possible for everybody to be 100% compliance, but we can always say, and this is, I think I would strongly suggest, and probably I will think of how to put it in a correct academic parlance, that can we put them into priorities, that these 10 points is for the beginners to begin with, and once they are comfortable, these next 10 points, these next points, so that they are comfortable in 30 points. And this is in adults, yes. In oncosurgeries, like which I am practicing, we are doing a lot of it, almost all surgeries, especially for transplants, other things. So at this, I can take it a liberty to request, madam, to have some consensus among the leadership of pediatric anesthesiologists to come up those points and set a target, as you have done for decreasing the morbidities, mortalities, and so on and so forth, that maybe in the next 5 years, let these points of the RAS protocols should be followed at least 80% of time. And this is how India can take a leadership under your leadership to bring this important, and I'm sure societies like Indian Association of Pediatric Anesthesiologists, and now Indian Society of Anesthesiologists, with its own College of Indian Society of Anesthesiologists, is a big platform with almost more than 45,000 members across India. And I personally know that the total number of cases that is coming from India is such a big number that we can always put that strong data to the world so that they can get some meaningful outcome or conclusion from this good clinical experience of our Indian population by Indian anesthesiologists.
Lots of brilliant ideas coming out in this podcast. I think it's a wonderful discussion that I'm seeing. Dr. Shali, another very important thing when it comes to pediatrics is for people who are not doing it on a regular basis, the one thing they always dread is a child desaturating. Now, when the saturation starts dropping, the anesthetist's heart rate starts going up, the cortisol levels are spiking. And there is now a lot of emphasis on this concept called para-oxygenation or apneic oxygenation. And we are seeing a lot of papers coming out on this subject. Can you just throw some light on this aspect of how somebody can use this concept in their day-to-day practice, and what are the benefits of this so-called para-oxygenation?
Let me just make things very simple for our listeners. We always knew the concept of pre-oxygenation. It is like denitrogenating our alveoli and filling them with oxygen, and as apnea sets in, that oxygen gets utilized. As simple as that. And that is how then we see the scale of our saturation sort coming down. So tick, 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 and then, yes, this is what happens. Having this scenario in mind, how we can help the babies or any patient for that matter, even adults, is some way as oxygenating. And that some way can be as simple as nasal prongs, maybe put nasal prongs while we are intubating or while we are bronchoscoping our children, so that due to the gradient itself, this apneic flow does happen in the alveoli, and we do get a little more time to do interventions. May it be a laryngoscopy in a difficult airway, may it be routine laryngoscopy and we just taking another attempt, or may it be a bronchoscopy or even a fiber optic bronchoscopy. So this is as simple a concept of para-oxygenation, and it can really aid everybody's practice is what I feel, because yes, hypoxia is the most dreaded scenario in pediatric anesthesia. We do not have children with cardiac anomalies, or unlike adult population, they inherently have a good heart. They are not going to have cardiac events. They are going to have cardiac events secondary to the hypoxic event. And if we can handle hypoxia, then I guess we are handling babies better, because the cardiac anesthesiologists are going to handle the cardiac babies. So for the routine anesthesiologist, this is a boon, and it can be simply taken up with nasal prongs or even an endotracheal tube, which you can measure from the nostrils till the tragus. Then you know that they are there in the pharynx.
Yeah.
I'm not even lying down to irritate and put a spasm out there. Let's give oxygen through that oral airway, close this, and let them do a bronchoscopy. The technique period can be prolonged for a while for sure.
And any
Until we
research
have a
ideas,
definitive way.
any research ideas that you can give young researchers out there when it comes to para-oxygenation or apneic oxygenation? Anything that has not been done yet, or anything that can be done in an Indian scenario?
Maybe how much ml per liter can probe how many seconds, perhaps, can be answered. I'm not too sure what protocol should be followed, because I guess it needs a mind which can really read mathematics here.
Dr.
And,
Rakesh, anything from your end for young researchers on this
I
topic?
think
Because it's quite an
pediatric
important topic, I
population
feel.
is absolutely. I think very soon another professional body, All India Difficult Airway Association, is coming up with guidelines, and maybe in another 2-3 months you will see how it comes up. But if you see regarding the pediatric aspect of oxygenation, not many robust randomized controlled trials has been published. So this area is absolutely open for a good amount of research, and probably I should not be saying, but I can say thanks to COVID that have allowed us to use the high flow oxygen therapy to a large extent, because at that time we understood how it works. It has proven its very well role in adults as para-oxygenation, or now we simply say oxygenation, para, pre, and I think limit oxygenation. How does it, or what volume is useful for pediatric population? Now, those who are pediatric anesthesiologists, I remember from my postgraduate days, there used to be a sheet on the anesthesia workstation, weight 3.5 kgs, all the drug volumes and everything is documented and mentioned on the sheet and pasted on the anesthesia workstation. Now, same concept has to be brought for oxygen. Oxygen is a drug and we need to understand it. It has to be prescribed. It has a dose, it has a duration, and it has a delivery device. We cannot use any device like anything. There is a role when to use nasal prong. There is a use when to use nasal trumpet. There is a role when we want to use oxygen using T-piece or GR circuit or a closed circuit, and when to combine them with high flow therapy, high flow nasal oxygen therapy. How much volume is sufficient? Also, we need to look for, though people are a little worried when Madam mentioned very strongly that we have to give oxygen. People say oxygen toxicity. Oxygen toxicity, yes, it happens, but it happens over 24 hours, and I'm sure that you're not going to manage airway for 24 hours. It's a matter of minutes and seconds. So how much oxygen flow? What should be the oxygen flows and the proportion at the extubation also? We have very small research on that aspect. Though we have always talked about in this podcast, in the researches, about the airway management in the start of surgery. Don't we have to extubate these small kids? They become more probably, I can say because of the surgery, when talk of cleft lip, palate, tonsils, probably they become more complicated at the end of surgery. And we have to be a little more cautious for extubation. What is the role of oxygen? Which device? For how much duration? And simply it happens when we say about airway management also for pediatrics, which Madam also emphasized. How many attempts? 1 attempt? 2 attempt? 3 attempt? What is the baseline value where you will say that, yes, we need to activate plan B. We need to go for plan C. It's a failure now. Because when we talk about the reserves into these kits, they have small reserves. They will not give us a very prolonged apnea time. If you see the studies which are coming from adults, using high flow nasal cannula oxygenation at flows of 60, 70 liters, probably the apnea time is 25 minutes, 30 minutes. In some studies, to the extremes, up to 40 minutes also. But I'm sure that this apnea time is not applicable for pediatric population. So we should not be translating, as we say, that these are not small adults. These are special creature which we have to identify and individualized. And I will put it now very strongly for pediatric. It's the time where we talk about individualized medicine, we talk about precision medicine, and where again the oxygen therapy has to be individualized. How much? Open to research.
Excellent. Both of you have been very nicely leading me to the next topic, which I would want to kind of discuss. Now, very nicely put about airway and, very good points, I would say, for young researchers listening on where to focus their energy when they want to do the next project. Now, you spoke about precision medicine, Dr. Rakesh. Now, we have been seeing the genetic, I would say, screening. Even if you take a pathology textbook, compare it to what it was 25 years ago when we did our medicine, there's a huge chapter only on genetic screening and genetics. Pediatrics is the fertile ground where when babies are born with syndromes or when they're born with something which we don't know what they are, come up with these genetic problems. So, Dr. Vrushali, the question is to you now, genetic markers, how important are they when it comes to anesthesia?
Yes. First of all, it's fascinating, isn't it? It's fascinating that we can tailor make. It's fascinating that if we understand that there is one gene which is now going to decrease the functionality of an enzyme, we probably have to decrease the dose. Increase the functionality of that enzyme, we might get a suboptimal dose, so increase the dose. That sounds extremely fascinating, and yes, it is opening up. So, and secondly, the genes will have an effect on drug metabolism, and probably a drug might have an effect on the gene itself. Midazolam is a wonderful example for that. So, it's coming up for sure. Hasn't percolated a pragmatic day-to-day practice yet, as it were. But this is something that will come up in a big way, is what I fathom, because there are anomalies, a lot of anomalies in children, and I think genetic screening can play a very big role in. If we have universal dosages, we will go to personalized dosages, as it were, in near future.
Thank you. I think we've been an hour into our discussion, and it's been wonderful, actually. Now, what do you see going forward? Now we're in 2025. Let's say 2030, again, if we are having the same conversation, what trends do you think have emerged in 5 years? Let's say we are having the same meeting, IJA Podcast is continuing into its 6th year and we are sitting and talking. So what do you think has changed now in 2030?
I must say this is one of the most interesting questions and thoughts that have been ever thrown at me.
No, we are getting better at IJA Podcast to throw these kind of questions.
I thought in future, immediately the first thought that ever arises in my mind is this. Even right now, while we are speaking, there are such discrepancies of resources first. There are clips and palettes done, even in IM ketamine and local infiltration, even today, for the want of a good pulse oximeter where Lifebox finally gives them one, and then they keep it. The one voice apparatus is kept for that particular child who won't be cooperative enough, or who is very small or the community is very big. We have that end of the stick here. And here we are talking about, I think my future is we come somewhere in between so that nobody has to struggle in pediatric anesthesia there. So I guess our thoughts should be rushing there when it comes to future of pediatric anesthesia and all the specialties of it. No continent in the world should be left groping in such disastrous circumstances. That's point number one. Point number two is there has to be pain-free anesthesia. So I can imagine with you, me and Rakesh ji, not again I think Rakesh should be telling me, oh, we're flooded with articles of wonderful pain management and successful acute pain reliefs and acute pain cures and a chronic pain coming up in a big way for children. And he would have answered how chronic pain is just not existing anymore because we prevented it in the first place, at least the post-operative ones. So this is what I imagine the future to be in the first place. And then, of course, there could be drugs which do not give side effects. I know it's a far-fetched dream. I would want that one pre-medication which tastes beautiful, which is accepted very well, which acts very fast, and which makes the child forget every traumatic incident. And the litmus test for that would be, he's going to look at us and say, hello, doctor, how have you been? Dr. Auntie, I met you somewhere, and probably I meet him somewhere in the mall. So this is what I would like in pre-medication. The introduction would be so smooth that there is not a single arrhythmia coming up, or there is not, or the child holds the mask by himself and feels so nice about the smell that gets emitted from that circuit that we hold. I would want the theaters to really look like aeroplanes to them. Or, I mean, I guess I can keep on telling you what I want in the future.
No, this is
I can go.
no, this is what visionaries feel like, or what they have as a dream, and it's nice to hear what ideally you would want things to look like in pediatric anesthesia, because that gives somebody who is doing research a goalpost to go towards, a vision to work towards. So that was wonderful. Now, coming to training, now we spoke about what you would like in, say, a pre-medicant, or how a theater should look. Coming to young anesthesiologists going into future, you are a part of the WFSA Pediatric Committee. You are going to be taking over as a president of the ASPA, and you play key roles in various board of studies. What advice would you like to give these young anesthetists who are specializing in pediatric care?
Okay.
They are the future of the country, of the world, when it comes to delivering anesthesia.
All right, buckle up, put your seatbelts on, roll your sleeves. You're entering an extremely fascinating super specialty of anesthesiology, where every minute is going to count, every second is going to count. Forget about that, but you have to be so present when you talk to the family. You have to be so present and so sensitive to pick up that particular sensitive kid who's going to require an extra care over and above what you would anyway give. That family, you are just be prepared to look into their eyes and understand what they're going through. Be prepared to keep everything that is personal to you going on outside. Be prepared to wear some clothes which are fascinating and have some cartoon prints on it. Talk to them eye to eye. Don't ignore the child. The child is going to ignore you. Never mind. He's going to listen to you, or she's going to listen to you anyways when you speak. They're petrified. Don't depend too much on guidance. Depend on your empathy first. So you will have to keep them abreast. You will have less reserve to work on. The physiology is not going to be on your side. The age is not going to be nothing much is on your side, and you're going to give the best that you could. So please, this specialty is for you if you are of that kind. Secondly, there would be one theater where an adult hernia is going on, and you would be struggling with a neonatal hernia, and your paycheck is going to be lesser. So be sure of that, because this country doesn't have insurance for congenital anomalies, and most of the neonatal surgeries do come under that.
I think we need to appreciate Madam, because in last minute or so, she has brought the experience of many decades in few very precious words. I think each word listening to her in last minute or so, it was just an, I think, summary of what anybody should expect, or anybody should be prepared, those who are coming in the field of pediatric anesthesiologist.
Yeah, you touched upon every single aspect, and it came from the heart. We could make out that this message to the young anesthesiologists across the world. I'm sure this podcast will be viewed by many people in the other countries. So it was a wonderful message. And I think we are starting this year with such a wonderful Editors Insights podcast episode, such amount of positivity. Wishing you a wonderful year going ahead. Thank you very much for joining us. Any final message to the listeners?
Well, what reminds me is a quote. It has just come to me off because I didn't know Murali was going to ask me this. The way we treat our children is a total reflection of what our society is. And I guess when the most vulnerable population comes to you, the way you are going to handle them, make them feel, is what your contribution or the rate, as it were, that you are going to pay for your profession, just for being here. So, yes, take care of them. Take care of children in the most empathetic way that you could. Yes, this is what I would say. And don't stop at anything, because the universe expands and everything expands, and even we are here to expand, to give the very best that we could. Yes, and
Thank
have
you.
fun. Have fun.
And
Pediatric anesthesia is fun as well. The litmus test to this is when that person comes again, because so many things are, so many surgeries are repetitive. They come back. If they come back searching for you, if they come, oh, where is that? Where is the doctor? He was wearing funny clothes. That's your litmus test of being a good pediatric anesthesiologist.
thank you. Thanks a lot. Dr. Rakesh, any final words for our
Absolutely. I
listeners?
think a lot of interesting research topics and what we can do. It's the start of 2025. I'm sure after listening to today's podcast, a lot of research ideas are there. From the advancement the pediatric anesthesiology has seen over the years, it's not the end. It has opened more arenas now. We have more gadgets, we have more techniques, we have more strategies. But on the same side, on the other side, in fact, we have more pediatric surgeons who are doing more complicated surgeries. Looking from open surgeries to the laparoscopic surgeries, now the robotic surgeries, minimal access surgeries, the arena of surgeries has opened up. The identification of the intrauterine anomalies and going to the surgeries, in utero surgeries, and another arena which has come up. With preterm baby with good survival, another arena which is come up. And the data and the research is not very conclusive coming from this. Though we have good pediatric anesthesiologists working in this area with good outcome, but that has to be consolidated. And we have to put a legacy to the budding pediatric anesthesiologist to get from their experience and provide the same quality of care to their children, which Madam just mentioned. That the best, you can say thank you notice when the patient comes back and says thank you so much. And if you ask that which is the next doctor you will visit if you have the same problem, and if you say you, this means you have done your job well. But on the other aspect, I'm a little tough on that side. And earlier I mentioned about think of one gray cell, one myocyte, one nephron, one hepatocyte. But now I will add on, think of that one emotion, that one feeling, that one quality of life of that bacha, a small kid, which with the longevity of life, he has to be there with us at 60, 70, 80, 90, and maybe another century. We have to think of, have I harmed in something that he will feel something at the age of 100 years? We need to look for. And this is what I'm sure the world around and the people like Madam and others in the pediatric anesthesiology will bring some more insight into the system, will be more cohesive, will be more united across the world with IPA, ASPA, WFSA, Indian Society of Anesthesiologists, everybody together to bring more research, to provide more quality care of our patients so that we feel happy. Thank you so much.
Thank you, Dr. Rakesh. That was a very poignant, I would say, deep thinking final words from your side. And what you said about that single emotion, I'm sure every pediatric anesthetist, every anesthetist listening to this conversation will take it in deeply and think about it after this conversation. So to all our listeners, thank you for joining on the second podcast episode of our Indian Journal of Anesthesia. And as we always say at the end, stay curious and stay safe. We will be bringing you the 33rd episode, which will be the author's views episode on the January issue of IJA. So till then, goodbye.